Hi, everyone. Welcome to Doing Sociology. Today we have with us Christa Wichterich and Maaya John, who will be talking to us about their latest book titled Who Cares? Care Extraction and the Struggles of Indian Health Workers. It was published by Zubaan in 2023. I welcome both of our speakers, editors to this discussion. Very happy to have you with us. Before we begin, I would very quickly introduce the editors. Christa Wichterich is a feminist sociologist specializing in gender and development. She was a visiting professor for gender politics at the universities of Kassel in Germany, Vienna in Austria, and Basel, Switzerland. Earlier, she worked as an assistant professor at Gilan University, Iran, and for 3 years at JNU New Delhi. Furthermore, she worked as journalist and was based as foreign correspondent in Nairobi, Kenya. She has published widely on neoliberal globalization, care work, and global care chains, feminist political economy, feminist political ecology, and international social movements. Her focus of empirical research has been in India. She is a volunteer with Women in Development Europe and on the scientific advisory board of the Rosa Luxemburg Foundation, Berlin. Presently in the Global Partnership Network of the University of Kassel, she organizes a comparative study in Ghana and India on to stay or to go, recruitment and outmigration of nurses from India and Ghana. Maaya John teaches at the University of Delhi. She's been researching and publishing on the politics of epidemiology and the history of epidemics. She's also worked on the relationship between caste, gender, and the labor market, the evolution of labor law in colonial and post-colonial India, gender-specific laws at the workplace, the history of educational inequality in India, and recent anti-rape agitations in India. She actively works with nurses' unions in Delhi NCR and is also active in unions of domestic workers and teachers. So I welcome both the speakers. To sort of start our conversation, could you both tell us about, the genesis of the book or the background of the book? Christa, would you like to begin?
Yes, let me tell you a bit about my background. I'm working and researching in the theoretical framework of feminist political economics. And feminist political economics.
Yes.
Okay. So my background is that I'm working and researching in the theoretical framework of political feminist economics since a long time. Feminist political economics considers gender with an intersectional perspective as a prominent structure of inequality in the economy and labor markets due to the gendered division of labor, apart from class, caste, race, ethnicity, age, etc. Since the famous debate about housework in Western sociology, feminist political economics consider care and social reproduction as root causes for the low valuation of women and their work, unpaid and paid, meaning that neoliberal economics and Marxist economics widely ignored social reproduction and women, which were moved by feminist political economics to the center stage. I have a keen interest to research how this devaluation is reproduced in Western societies and in post-colonial countries as well. Earlier, I did research on other women-dominated global value chains like textile and garments, where we find another kind of devaluation of women's work due to a narrative of nimble fingers. In the wake of societal and global inequalities, each value chain implies a gain and a drain, brain gain and brain drain, skill gain and skill drain. Another source of inspiration for me was and is the German hospital movement. It is alive and kicking for nearly 15 years, shifted from a conventional trade unionist repertoire of decent wages and work conditions to the politicization of care, critique of the neoliberal hospital management, and so on. It stresses that health is a common good, not a commodity. In Germany, as in many countries, the COVID pandemic and the related crisis in hospitals and the empathic applause by citizens all over, all this worked as a driver for mobilization, organizing, and for strikes. That made me ask, how do struggles of healthcare workers emerge? What drives them to organize and protest in India? And my third entry point is from a methodological point of research. Care work and global care chains are an outstanding example for an intersectional perspective, because here gender, class, caste, a racial and an international division of labor intertwine. My research interest is to link feminist structural analysis of political economy to discourse analysis and to actor-centered analysis. Hence, I wanted the book to unveil the nexus of intersecting power relations, which reflect complex realities of inequalities. And that is what sociology is all about. It is about complexity, inequalities, differentiation. And finally, when I stayed 2018-19 as a fellow in Delhi, I was keen to explore these questions and understand these perspectives in Indian society and economy, where I had lived for a number of years. And then, fortunately, I met Maaya. And so we together started to think about this book.
Thank you, Christa. Maybe Maaya, we'd like to hear a little bit from you about the background of the book.
So, of course, I would begin with saying that this work is, of course, it has tension and certain dialogues that are going on. And that's also because, as editors of the volume, we are carrying with us, slightly different frames and ways of understanding the on-the-ground situation. So, I would say that this is a work which is a theater of dialogue, and I begin also by emphasizing that I just heard my colleague Christa position how she looks at this work and this research that unfolded. I would say that as a scholar, as an activist, I do see this work as part of an interesting tradition of theorizing around social production. And I do believe that there is some solid and very good Marxist work on social reproduction. And we've tried to engage with, that scholarship and that tradition in meaningful ways. I'd also like to say that, I'm also talking to respond. I'm also responding to my co-editor, talking with her. And this is that, it's not just that this book works with concepts like undervaluation or just simply things like, nurses or various segments of nurses are underpaid. We're also working somewhere with this entire reality check, which has been that, it's more, if you're using a concept like value, right? And you're looking at value as a concept and then looking at this workforce, which is nurses. Very important to keep in mind that more than undervaluation, there's actually differential valuation that is happening, where you actually have, in the Indian context, nurses who earn 2 lakh rupees per month and nurses who earn 10,000 rupees per month. So you have to also understand how, in a very complex way, a differential valuation, a very segmented labor market is playing itself out. And I would say, therefore, that, as an editor, one tried to steer clear of gender essentialism, because, how do you explain this differential, valuation of labor when one woman who's a nurse is getting 2 lakhs and another woman who's a nurse is getting 10,000. So, of course, the picture is much more complex. And so there is an effort in this book also to steer clear of gender essentialism. And I would also say that this work, for me, has been a very, very important journey, because one has tried to connect what I am learning on ground as an activist, helping many of these and being part of many of struggles of nurses and other, hard of workers, and bringing that into the theory, bringing that into the frame. So I'll just, quickly say that, one really hopes that whoever reads this work, who cares, will see that a lot of this writing that's been put together, overall, even me as a scholar, I strive to make my academic work very closely linked to social concerns, So this is while participating in the struggles of nursing labor, that one has actually envisaged this book with Christa. And therefore, it has been my understanding when working on this volume that, we don't struggle in a fit of absent-mindedness, but we also reflect. And this book, this collection of essays, is a part of that critical reflection. So this work, Who Cares, is a reflection from the ground, a critical reflection from the ground. And in that sense, it is also, for me, an embodiment of the struggles in the realm of theory, in the realm of social sciences. So while doing that, we also know, that the category of nurses as well as other health workers is therefore fraught. It's fraught with, certain tensions, and that's what we try to bring out in several chapters in this volume. There are segmentations within, and therefore nursing labor is not homogeneous as a category. Nurses are not a homogeneous group. And there is an alignment of these, various segmentations within nursing cadre with historically constituted entities like class, caste, gender, etc. So this work is also a kind of participation with, within dialogues, dialogues stemming from movements, and not just what I'd say a sterile, abstract academic writing or collection of, essays.
Okay. Thank you, Maaya. Thank you for that response. I think since your book talks about care work and you did mention nursing, maybe you could also tell us a little bit about the political economy of nursing. How do you see, or how do you conceptualize the political economy of nursing, and what are the changes that have occurred with liberalization on the same?
Maaya, would you like to start and can add on?
Okay, sure. So it's a very good question. Thank you for, sharing this. Let me take the first part of the question, and then I'll come to the impact of what you're identifying as liberalization. Now, the political economy of nursing, if we try to understand that process, it has to be situated in what, I call the condition of syndemic. By which I mean, that there is a sinister synergy between the economic vulnerability, social oppression, and a particular way in which the health system is organized in India. Now, within the families of the laboring poor in our country, who are the vast majority, care work, is predominantly considered the responsibility of women. So laboring poor are actually, caught in the cog of expanded reproduction of capital. And, it is sustained by very crucial labor performed by women. Now, when we move, however, in a larger social scale, the social reproduction of society within which health is a very important component, and that's the focus of the work, Who Cares? See that, it's hierarchically structured. Social reproduction is hierarchically structured. So historically, the early development of what we call healthcare, formal healthcare, there was an effort to make a distinction between different, category of workers, while many of, the activities, the performance of work, which we call broadly healthcare work, on the ground was quite common and remained quite common. So we find that, if we try to understand the political economy of nursing as it's evolved, to create a very sharp distinction, nursing work was increasingly feminized. So what I'm trying to say is it was not as if it was the, natural extension of the principle of being woman and it automatically happened. It was very consciously created, and it was built over a period of time. So rather than the woman nurse or the female nurse being, I would say it's actually something that is a historical product. It was historically constituted in this way. And here I would say that again, this volume, who cares, substantial portion of the scholarship here points to the fact that with professionalization of nursing work, especially in the latter half of the 20th century. And we see this across the world. Some of the scholars who wrote for the volume, in the case of Italy, Germany, etc., brought this point out. So, there's a professionalization abroad as well as in India in the latter half of the 20th century. And with that, nurses increasingly began to assert that their work demanded specific training and skilling. So within this tangent, within this moment, nursing work came to be articulated with educational access, the question of educational access. And educational access, of course, for our country has remained limited, very limited for the majority of people. And so correspondingly was the access to quality healthcare facilities also for the masses of Indian people, very limited. Now, we know this, that, the history of India post, 1940, amply shows that, the rich continued to go and opt for private healthcare facilities and even went abroad. The poor in this country, have remained heavily dependent on limited and poorly run public healthcare facilities. Now, what I'm saying is that, social reproduction of people in this country, social reproduction of people, wherein healthcare is an important part of the story, an important component, is actually something which is very closely intertwined with the social reproduction nursing cadres, something, this book again emphasizes very well. This social reproduction of nursing labor, nursing cadre is, of course, as was brought out by the various scholars in the volume, it's imbricated, the social is imbricated along the lines of caste, income, and region. I think, the work of scholars like Panchali Ray, who've written a chapter, Sneha Makkad, Hemantika Basu, they bring out this point well, that there's this sharpening of, segmentation amongst nurses with the professionalization of nursing. Now, about liberalization and also what, is known as neoliberalization and its impact, a quick point. Concepts, liberalization, neoliberalization, they need to be historicized. And when we were writing the, the introduction to the volume, another very interesting dialogue on this, and we discussed this. So, for me, the term neoliberal, is used in this volume, this book, Who Cares, to highlight three things, three tendencies in the political economy, which are essentially, the overall goal of cost cutting. It's linked to that. So you see the trend of, or the tendency of less state. That is typically what we identify with neoliberalism. More market and more individual responsibilization of citizens. Now, having said this, these tendencies which are typically linked to what we identify as neoliberal, the concept itself, neoliberalism, really has to be used very cautiously, when we're talking about different parts of the world, and we can't, use it equivocally, across the global north and global south. So I would say you use it in a way in which it, you are able to show the complexity of how things are working in different parts of the world. So I would say, like, this grand retreat of the state, which is such an important part of the concept neoliberalism, as witnessed in the global north, is not something that can be easily generalized to the post-colonial economies of the global south, such as India. And I say this because, in the case of the global south, we need to recognize that there's this continuum in the inadequate supply of state-sponsored healthcare services when compared to the actual growth of healthcare needs in the country, such as India's healthcare needs, the way they've grown. Nowhere since 1947 have, the corresponding state-sponsored healthcare facilities expanded in the same way or the same percentage. So given the widening gap between demand and supply for healthcare, successive governments in a post-colonial economy like India have actually pushed through measures that allow for greater penetration of private capital in healthcare. And of course, its corresponding development, the persistent decline in per capita government allocation of funds towards healthcare. So in this way, I'd say that even though there has been an overall gradual increase in annual budget expenditure of various post-colonial governments in India, the much faster growth in private investment and the emergence of a very segmented private sector in healthcare actually represents certain specificities in the crisis, in the problem of social reproduction, which cannot be easily captured by conceptual frameworks, simply cut, copy, paste, from the global north experiences. So I would just say that in response to highlighting some of the current scenario and how things have been historically working as well in India.
Yes, thank you, Maaya. Christa, would you like to add something?
Yes, that was always a very controversial point between the two of us, because for me, the perspective is, it's clear at the core of the political economy of nursing is the neoliberal organizing of the health system in India. And that means for me, it's a shrinking of the public sector, it's a shrinking of public services, and an expansion of the private profit-oriented corporatization of health and healthcare. And the third, what Maaya mentioned already, kind of responsibilization of individuals in terms of labor and costs. And the driving force behind this is the minimization of cost and the maximization of profits. What means, and I think this was different in the first phases of post-colonial India, that not human rights or health for all is in the forefront, but profit-making in the health sector. And in this context, again, gender, class, caste, racial, and so on, division of labor are used to set up this hierarchy. And for me as well, this hierarchy in the health system is really a focus in the book, because this hierarchy is instrumental first to increase profits through segmentation and tailorization of work and a differentiated payment to upgrade and downgrade work and recklessly extract care from those at the bottom of the hierarchy. And secondly, differentiation and the division of the workforce is used to make organizing more difficult, or it's instrumental to make organizing more difficult. Additionally, I would say that important for the political economy of nursing is the entanglement of the political economy and the cultural political economy, because stereotypes and stigmata and norms and values ascribed play an important role in defining the work and the status of nurses. Yes, and we have seen very much that liberalization, which led to privatization, has changed the rule of the game in the labor markets. We know that dumping wages are paid in the private hospital sector. Young nurses, after their training, who need some practical experience, are forced to sign bond contracts, meaning they are living in a setup similar to the dormitory factory regime, for example, in textile industries, 24 hours available and are not allowed to leave the hospital and change their employer. To lower costs, private hospitals try to employ more casual, flexible, and informal labor so that privatization goes along with casualization and informalization of labor, constructing a precarious class, a healthcare precariat. And as mentioned already earlier, the concept of political economy stresses the role of the state regarding budgeting, liberalization, withdrawal from provisioning, intervention in the market, regulation of the healthcare sector and labor, and finally regulation or promotion of out-migration. And privatization of training, where Maaya will talk more about it, I guess, is part of this process. And with regard to global care chains between countries of the global south and the OECD world, another asymmetry or structure of inequality has emerged in this political economy, namely skilled training is done in the country of origin of the migrant health workers at the expense of the concerned state or the individual trainee who goes into debt, while the usage of skills is in the more wealthy destination countries. Yes, this is what I would like
Thank you
to add.
for, to both of you for highlighting how, the political economy of nursing has been impacted with neoliberalism. And the way I see it, and I'm also coming to the next question is, in the recent years, post, one would say, a withdrawal of the state in India, one has seen the growth of private players in the healthcare industry. We've also seen a surge in medical tourism. Now, how has that impacted care work in the country? Maaya, would you like to begin?
See, I would just like to answer this question first by, highlighting something which I did share a few minutes back, which is, and this is also because, I'm a historian. I'm looking at certain historical developments, and therefore also thinking through this, the response to your questions, and also looking at the kind of work that finally, culminated in Who Cares, this book. So, I would say that, again, I mean, the kind of changes that we have seen in the healthcare sector, if you again link it up to, the concept of neoliberalism, or what we are calling as the last 30, 35, 40 years of, what we call neoliberalism, I would just like to say that, it's important to factor in again the element of the continuing precarity, and a very long trend of informalization, including of nursing labor. And then we can better understand what it is that has changed in the larger continuum, particularly in the last 30 years. Now, why I'm saying that, I do not necessarily see informalization such as of nursing labor as a very recent phenomena of the last 30, 35 years linked to neoliberalism. Because, in our country, India, 97% of the workforce has historically been outside the purview of the country's labor laws, and now what we're seeing in more recent decades is that even those sections of the workforce, which were better organized, which we call the formal sector, even there the labor laws protection or protective, cover is being retreated. And in India, for example, the labor codes and many other labor law amendments have done that in recent years. So I'm saying there's a larger history of, exclusion, of precarity, and in specific cases of healthcare and healthcare labor. It's very interesting, again, as a historian, to bring this to the table, that when this country was formulating its constitutional roadmap post-independence, we know that the Indian Constitution was divided into what is known as the directive principles section, okay, and what we call as fundamental rights. And again, the important rights which people had actually in this country been struggling for and had made part of their, agenda for the new India, were very conveniently relegated to the directive principles, which depend. So this is all like the right to education, the right to healthcare, etc. Was all relegated in the directive principles, which depends on they're actually in a legal document, that portion which says that which is the state is not legally bound. They're non-justiciable provisions. So I would say that given this, therefore, there's a longer history of how piecemeal healthcare a very precarious labor, therefore, in healthcare has existed historically speaking. And in the last 30 years, which is identified as the era of neoliberalism, we're seeing an intensity to the precarity, and we're seeing some very interesting new developments. So let me highlight what I would see as what is happening in terms of the private players in the healthcare industry, with the very, 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 very rapid withdrawal of the state in a, of course, larger, historical trajectory of the state really being very minimal anyways in the Indian context when it comes to healthcare. So let's say that the state, currently in more recent times is increasingly being providing what we would call these packages of health insurance. You have these various Pradhan Mantri Yojanas, etc. And, I would see this entire exercise, this tendency is somewhere like representing a kind of a Trojan horse phenomena, wherein, the ordinary people, common people of this country are encouraged to go to various private healthcare institutions, private hospitals, with this assurance that the government will pay a subsidy for, medical procedures, diagnostics, etc. Now, so let's say, there is already this, pushing of people into a dependency on private sector, on private players. And simultaneously, you're seeing that, government hospitals continue to be, underfunded. And we see that, these government hospitals, the public sector ones, are delegitimized in terms of, being heavily understaffed for doctors, nurses, and other specialists. And therefore creating, very easily creating and perpetuating this perception that in government or public hospitals, there are these long queues and these hospitals are inefficient. And therefore, for, pushing ordinary citizens of this country to private hospitals in the hope, of course, that they'll get some government subsidy. So let's say that, what I'd see as a phenomena that's becoming more intensive, because we have had private hospitals in the landscape of India's healthcare since a long time. And similarly, we've seen private nursing institutions also in the Indian landscape since the 1970s. But what we're seeing currently, the intensification of that process. So I'd say that the private public partnership model is becoming more intensified and definitely coming in many, very different formats and posing a huge problem in the real sense. The government many times is investing indirectly in these private hospitals through these insurances. Meanwhile, of course, the private hospital, in terms of being workplaces where nurses work in very large numbers, the conditions of work hospitals. I'd also say that, you can understand what's unfolding in terms of this public-private partnership model in healthcare, and its negative impact in terms of, how a lot of prime land is given, as subsidized. Hear me? Sorry. I think I got disconnected.
I think, yeah.
So one, I would just say that, the public partnership model, the way it's been working in more recent years, is that, we're also seeing the government give subsidized land to these private hospitals, with this, of course, agreement that these hospitals would set up more branches, private hospital branches. And the agreement is such that these hospitals, in return for the subsidized land, are supposed to then provide a certain number of beds to the poor. However, we know, the medical facilities extended by private hospitals to the poor are of dismal, terrible quality. And so, you're actually seeing, on the face of it, these kind of schemes, these kind of policies, being implemented by the state. And the repercussion, of course, is again, a huge crisis for social reproduction, with the majority of people in this country still struggling to avail of quality healthcare.
Thank you, Maaya. Christa, would you like to add anything?
Yes, actually, your question was for medical tourism. And medical tourism, I only want to say briefly, for me, is an epitome of commodification in this sector, and not the right to every citizen to health care is a priority, but profit making is a priority. And I haven't done any research about medical tourism in India, but I can say about Germany, where we have medical tourism as well. And we have a dual insurance system, a public and a private one. And after establishment of the medical tourism, doctors and clinics who can earn more money in medical tourism withdrew from public institutions and public services and offer their costly services only to people who can pay the high fees. And yeah, this is just an image for what is happening in the sector. And yeah, Maaya was saying it's a kind of continuation, but I feel it's more in the recent years a kind of turnaround. That I think the proportion of public and private changed from 25 to 75 in college education, in hospitals, and so on. And in the recent years, this process has been very fast, so that I'm afraid we should call it a real neoliberal turnaround.
Right. In your book, you write about something called care extractivism. Could you tell us, how do you conceptualize care extractivism? Christa, would you
Yes,
like
I
to
think
Yes.
yeah, I start with this because I coined the notion of care extractivism as an analogy to resource extractivism. During the financial crisis, 2008 and 9, resource extractivism became popular as a development strategy in the global south to overcome the crisis. And I proposed the concept of care extractivism to highlight that there's not only an intensified extraction and commodification of minerals and raw material, but of the human and social resource care as well. The concept tries to capture the processes which integrate resources which have been till recently outside of the market into domestic and global markets and into trade. That actually means an expansion of markets and an intensified commodification of care work, which cause a depletion of the workers' bodies due to non-decent and appalling working conditions. Paradigmatic is the extraction of healthcare and nursing, which results parallel to the degradation of natural resources in overburdened and underpaid staff, a lot of underpaid staff, mostly women, and in the depletion of human resources to an extent that in a number of countries, burnout and depression are recognized as health hazards of professional nursing. And scheme workers like Asha's work, this reveals that voluntarism or so-called social activism are the most insidious form of care extraction for the purpose of cost optimization. Now, transnational care extractivism and export of care workers have been normalized with the keen interest of the global South states in remittances as a development strategy, and the keen interest of global North states in a strategy to overcome the crisis of social reproduction in terms of shortage of healthcare personnel by importing migrant labor. So let me summarize the constituents of care extractivism as I understand it: intensified commodification, market expansion, relation of power and subordination, and depletion of human bodies and social resources. However, my motivation to conceptualize these processes was not only academic, but with a practical political orientation towards struggles. It is a fighting, challenging term which provokes attention. It is sometimes contested by Marxist colleagues who argue that the concept of exploitation is well established, recognized, and sufficient to analyze the relation of power and violence vis-à-vis resources and workforce. They consider extractivism as a form of overexploitation. So that was my intention to introduce the notion, and I find it very fruitful to work with it.
Okay, thank you so much. Coming to you, Maaya, I mean, both of you have also contributed essays in the volume. Your essay in particular, it looks at the educational hierarchies and segmented labor markets. Could you talk about how educational hierarchies impact segmentation in the nursing labor market?
Again, thank you for the question. Let me say that, there is this tradition of critique of political economy, which emphasizes the link between education and labor market segmentation. And, one of the very initial, seminal writings on this question, linking education and the labor market segmentation, is, the work of Gintis and Bowles. And I would say that, therefore, it was a very important question for me when I was contributing to this collection, that, how is skill produced in society? And, obviously, when we're looking at a contemporary scenario, skill is, produced, reproduced in connection to educational access. So what kind of education you're getting, to what level of education you're able to achieve or reach, that is determining, ultimately your life trajectory, particularly where you're going to enter the labor market, what kind of job are you going to get. Now, the larger argument, of course, in my own essay in this volume was that, the unequal educational opportunities are very rampant in India. And essentially, this inequality in education amounts to the reproduction of hierarchical and a deeply segmented labor market for healthcare services. And, you can understand this in terms of the fact that, those kind of families which have better conditions, economic conditions, resources, are able to put their children into levels of education which can make them doctors. But that cannot be a story for every family in India. And therefore, you will see a segment of, families in this country who don't have those kind of resources. And therefore, their children go to different types of schools and go to different levels of schools. And from which you see, of course, a cadre of different health workers, which is nurses. And then, of course, those who are in our country who are in the margins of education are typically, have incomplete education, very poor quality education, then end up, of course, in the lowest rungs of the labor market, including the lowest rungs of the healthcare, or more specifically, the nursing labor market. And therefore, if I focus just on, the kind of work that one, brought out in my essay, there is this spectrum. So if you look at, nurses themselves, and I keep saying this, that there is no homogeneous category of nurses in this country. And if you look at the broader pool of what we call nursing labor, then of course you have a better place, well-paid nurse of the public sector who's got a permanent contract. Then within the same public sector hospital, you can have a contractual nurse with lesser salary, lower salary, and less rights in the workplace, even very often less organized in trade unions. And then if you move in further into the lower levels of a public sector hospital, and you have nursing orderlies, what we call ayas, the cleaning staff, sanitation workers, etc. And within that segmentation itself, you can trace back the different stories of differential educational access. And therefore, and when you further take your magnifying glass and look at the nursing labor market, then of course there's another very clear-cut division that works, that is the private hospitals on the other side. And in the private hospitals, typically look at the kind of nursing personnel who end up in private hospitals. Their life trajectory shows that they've obviously come from circumstances, from certain kind of inherited inequalities, which has not been able to, that has not facilitated a level of education in the best, nursing institutions of the country that are backed by the government, but they've actually done their education in nursing from a private institution. And so, of course, those who have, availed of nursing education in private nursing institutions, and particularly what I'd call private nursing institutions of, B-grade quality, not that good quality or standard, they, of course, end up in more precarious job contracts in the private sector nursing institutions. They are, of course, in the case of nurses ending up in the private sector hospitals, they're typically people who've had to take loans to actually pursue even their, nursing degree, their BSc nursing degree of 4 years. And of course, this points to the essential fact that our country lacks adequate public institutions for, medical, courses, nursing courses. And so a large number of people in this country who aspire for professional jobs are, having to, pay from out of their pocket by taking loans from banks and then pursuing these professional degrees, ending up in a debt trap, having to pay back their loans, and therefore immediately taking up whatever job is possible, which is usually in the private sector. So I would say that this is an important phenomena that my work tracks, and my work tracks this. My essay tracks this also. Again, this is a phenomena of unequal education, where you have a spectrum of poor quality nursing institutions exist right from the 1970s. And you also have, a segment, a small limited number of very prestigious government-funded nursing institutions, where again, a select few are able to make it, come out with these degrees and the prestige of, coming from the government, nursing institutions. And therefore, they have an advantage in even, getting the permanent contract job, the permanent contract or the permanent jobs in the public sector hospitals. So, I would say that the nature of one's work has been to show the connections between differential education, differential access to education, what type of nursing institution did you end up studying in, and therefore, what kind of nursing job did you end up in? And the larger point, therefore, has been in my own work is that, therefore, we have to be very careful and not essentialize care work. And we definitely should not homogenize, the category of nursing labor, because if we do so, if we slide into something like that, it does more harm, than creating possibility for more critical reflection, especially the possibility, particularly through the solidarity required between different segments of nursing labor.
Thank you, Maaya, for that elaborate answer. Now, Christa, coming to your essay in the volume, you write that, and this is something which really struck me as I was reading your essay, was that you draw from Michael Burawoy's idea of public sociology to politicize care. In fact, I just take this opportunity and mention that, when we started this platform doing sociology, we were very much influenced by his idea of public sociology. So, yeah, so I mean, when you write about the need to politicize care, why do you, where do you see the need, one, to politicize care? Secondly, could you draw from some of the recent experiences of nursing in nursing during the COVID-19 pandemic?
Yeah, let me add one sentence to what Maaya said about skills for the labor market, because there's an interesting tendency now in India in the recent years that more customization of nursing training has taken place according to nursing requirements in UK, in US, Canada, Australia, Japan, and so on. And there are contracts between governments over there and states in India and private colleges. So I would consider it a task of public sociology to make issues like this, structures of political economy like this, public, and bring these academic analysis we are doing into a dialogue with broader public discourses. And we wanted to politicize care in this book by linking up our academic analysis or the analysis in the different papers in the book with the struggles of healthcare workers, and take up their concerns, but deconstruct at the same time the private character of care and expose its public nature and stress health and nursing as commons, meaning that every citizen, every human being needs it, and that they are not just in the interest of a particular group of workers or a particular trade union. Care is a political issue, an issue of the entire society, not an individual issue. If we refer this discourse to the human rights framework, then we can argue that in order to ensure health for all, as a human right, everybody has a right to quality care and nursing. And this is very much, I think, a topic of public sociology. And the pandemic and the appalling deficits in the health system and hospitals have brought this to public awareness. Therefore, they were an excellent occasion for public sociology to politicize healthcare. Nursing work and workers have got as much attention and recognition as never before. However, singing for them, clapping hands, and banging pots is only a symbolic form of acknowledgement. And the new awareness created in this pandemic situation didn't last long and is not sufficient to put some pressure on the state and the private sector to improve the working conditions of healthcare workers. It is a task, I think, of public sociology to search ways and spaces to continue the politicization. One example is to link the issue to the actual struggles of health workers, because during and after the pandemic, scheme workers and nurses realized that the applause didn't have any impact on their salaries or permanent recognition. They intensified their protest against low payment, non-recognition as workers, overburdening, and exhaustion. In particular, alliances between ASHAs, nurses, doctors, and other workers in the health sector politicize the issues by asking for increase of the health budgets or attacking privatization and the neoliberal management, exposing the greed to make profit in the health sector and the recklessness of the state vis-à-vis scheme workers. So public sociology that politicizes issues contributes to building up pressure against political and private actors and supports the struggles of the concerned workforce.
Thank you. Thank you so much, Christa. Now coming to our final question to both of you. You did mention that the nursing market, I mean, not all nurses are the same, and there is segmentation in the market. Different nurses have their own struggles. Maybe if we could hear about some of the different, recent struggles of the different nursing unions in India. And a second question to that would be, what are the ways in which the different struggles can be united? Maaya, would you like to begin by answering? question.
Okay. Two very, very interesting questions. Um, Now, I would, of course, say that, if we're trying to understand the recent struggles of nurses in India, um, one very important fact, dimension, is that, somewhere these struggles of nurses, be it nurses in the public sector, be it nurses, uh, um, um, in the private sector, those struggles are somewhere working within a larger plane. And that is a plane in which, we have seen, as I said, a steady move towards, a push towards the professionalization of nursing work, with the introduction of, what we'd say, formal nursing education in India. As I said, in the latter half of the 20th century, there's a formal nursing degree that is envisaged. And what happens with, this steady professionalization with the introduction of formal nursing degrees in the country, is that, um, is that nurses, who attain this kind of formal nursing education and, assert this professional status within a hospital, they begin to, slowly devolve, sublet what is the more menial, mundane physical tasks into, onto nursing orderlies. And this is, of course, created a very distinct division in hospitals, where you have a higher segment of nursing personnel who are fighting their battles, their struggles in a particular vein, right? And they are the more organized segment of nurses, right? In any establishment, so they're better paid. Um, they're asserting their professional, status, their skill, and they've devolved a lot of menial work onto other, sections of staff in a hospital. And therefore, I would say that if we look at this larger process that I'm calling steady professionalization, leading into and feeding into a segmentation in the workforce of nurses, then I would say that if you look at the government or public sector hospitals, this has meant that, nurses who come with these, professional degrees and status, they have obviously, enjoyed and exercised a much higher level of organization and trade union activities. And therefore, way right into the 1980s, way back in the 1980s, nurses in public sector hospitals had already created like a platform, All India Government Nurses Federation. Now, public sector nurses, of course, their struggles are focused and anchored on, workload concerns, like having to do a lot of double shift, or, of course, in public hospitals, a very big issue is very, very disbalanced nurse to patient ratios. India continues to flout and violate World Health Organization prescribed nurse to patient ratios in general ward and even in specialized wards. So structural overwork, lower payment than other skilled professionals who are in, the public hospitals. So of course, we have seen that, this cadre of nurses who have what we call permanent job contracts in public hospitals and government hospitals. They are, of course, better organized. They're also covered. Their rights are also more covered and guaranteed by the labor laws of this country. And therefore, they've also been more effective in terms of pushing through regular pay revisions, salary revisions. So they have been able to put across a very strong case for their salary enhancement in front of central government pay commissions, 2008 and 2016. I would also say there's another interesting trend that we have seen, and I've seen this escalate in the last 20, 25 years particularly, is that, you do see public sector nurses, including the platform that I just mentioned, the All India Government Nurses Federation, picking up, these issues of outsourcing and contractualizing of nursing work in government or public sector hospitals. But the important point is that, they may be raising these issues as, unions of government nurses with permanent jobs, but still, their unionization is not being able to stem the tide of privatization within the public sector, healthcare institutions, or what I mentioned earlier, they're not being able to resist, despite their unionization, the various formats of, public-private partnership, which is unfolding, very often affecting even their work in terms of bringing in more and more contractual outsourced nursing labor into the hospital. Now, when we move down the nursing cadre, into other lower segments. If you just look at, again, the government hospitals or the public sector hospitals, you'll see that those nurses who are contractual nurses, they don't have permanent contracts. There you will find that, their unionization is fleeting. They're not easily incorporated in the existing union of, government hospital permanent nurses. And even if they create their own unions, the unions are, very touch and go. They don't, sustain themselves as unions over long periods of time. So I'd basically say that, once you cross, and go down further into the segments of nurses, you'll see that the unionization is more fleeting. Of course, when you move into the entire other sector, which is the private sector of hospital care, there the unionization is even less. And you see the nature of the struggles of nurses has also got a different emphasis, slightly different tenor and texture. And I'd say that, given therefore the sharp hierarchy in the nursing labor market, the segmentation that's very evident, of course, what this volume also brings out is that there is a lot of difficulty for effective, sustained unionization. Thus, we see what, I borrow a term from, labor historians, which is we've seen like the vernacularization of nursing labor politics. And I basically, I'm referring to the fact that, nurses, especially those in the private sector, are using caste, regional identity, community identity, etc., to unionize, to create a sense of collective. Not using the conventional, parameters of unionization, but more regional identity, caste, etc. So therefore, the vernacularity of how they are, thinking about their politics and collective. And of course, this allows for, unionization to some, degree. It allows for collective struggles, but the vernacularity of the way they're organizing themselves, particularly in the private sector, it's actually creating a very it's actually creating a very fragmented struggle of nurses in the private sector. So that is another important trend that we see, that a vernacularized form of nursing labor politics, particularly in the private sector, where it's harder to organize. You can immediately be fired from your job of a nurse if, the private employer figures out that you're trying to create a union. So there are other mechanisms that are used to, to create some sense of collective and collective struggles. And it breeds what, we have identified in our work also as, unfortunately, a more fragmented form of unionism. I would just, like to end here, and Christa can add on, is that, when we look at places like Delhi NCR is, of course, the capital of, the health capital of this country. That's why I'm looking at this region. Or even if you look at Kerala, both these places, Delhi NCR and Kerala, have shown some very interesting strike waves of, nurses in the private sector. And, I would trace this strike, intensified strike action around certain periods of time in the last few years, to the fact that, in the public sector, in government hospitals around 2009, 2010, government hospital nurses got the benefits of the sixth pay commission. So their salaries really went up, and other allowances and benefits went up. And the salary of nurses, very often with this, same degree, they also have a nursing degree, their salaries in Kerala and in Delhi NCR, you see a very interesting strike wave that's coming out of, the fact that the government hospital sector has seen a huge, salary hike for government hospital, permanent nurses. Again, this phenomena repeated itself, around between 2016, 18, because you have the the seventh pay commission kick. So do I need to repeat anything or?
No, you can continue from, yeah.
So I would just like to conclude by saying that, we've seen interesting strike waves in places like Kerala, Delhi, NCR, which actually closely map down to what is happening in the government sector in terms of what rights and benefits government hospital nurses have, wrested from the system, from the government, has of course created an angst amongst private sector nurses. And so they have, seen these very spectacular strike waves in 2009-10, then again in 2016 to 2018. And I would just, end by saying that, despite a very, repeated action in terms of, collective action like strikes, we, however, find that in the case of both the public sector government hospitals and even in the case of the private sector, the initiatives is mobilization. The initiative of mobilization is somewhere locked. It's trapped within this grid of individuated, disparate struggles, wherein, the all India level coordination, or let's say even the industry-wide mobilization that is required, to really get at to target the heart of the crisis in social reproduction. Those are not possible, because of these struggles being so fragmented, individuated, and very disparate struggles. So this is a phenomena that we're seeing. We're also seeing a lot of bureaucratism, especially within the government sector, nursing initiatives at mobilization. However, having said this, there's always a silver lining, and I would, rest my case here by saying that, wherever we would see the lowest segment of nursing labor, such as nursing ordinaries, or even the more vulnerable segment of nurses, such as those in the private sector, such as those who are contractual nurses, them organizing and struggling is still, somewhere silver lining, because these kind of struggles of the more vulnerable section of healthcare workers, or even what I'd call frontline healthcare workers that Christa will talk about, Anganwadi and Asha workers, their struggles at least have the potential to disrupt the, chain of constant differential valuation of labor, the cost cutting that is happening in the health sector, and therefore the corresponding poor quality of healthcare provided to the country's people. And I would say the way forward would, of course, therefore, given this larger observation about where the silver lining lies in many of these struggles, especially of the more vulnerable section of healthcare workers, it's the way forward really is common demands, the common demands pertaining to struggles for wage boards, that would standardize and increase the wages or salaries, especially in the private sector. Better nurse to patient ratios is another very crucial common demand. The right to form unions and not be victimized for it. And of course, the larger, initiatives that help forge an alliance with the people's movements for quality public healthcare. These are all the crucial, demands, common demands that become a way, an avenue to take forward, the struggles of nursing labor in India, given the kind of challenges it's facing today.
Thank you, Maaya. Christa would like to hear from you now.
Yeah, I have not much to add. What I found very interesting was UNA, the United Nurses Association, which was founded by male nurses who had migrated abroad and found it difficult to earn enough to repay the loan they had taken for their education and placement. So they came back to India, and then they started to organize nurses and to struggle in India. And they were quite successful with regard to the private sector in Kerala. And the interesting is that they did this in alliance. The Nurses Association did this in alliance with the Nurses Parents Association, which was concerned about the repayment of their educational debt. And amazing for me was that men were the leaders of the union and women were the members to be mobilized, and there was not a slight critique of the traditional gender division of labor. In UNA, the male leaders justify their dominance with women's obligations towards the family and children. So they confirm very much the traditional gender division of labor. For me, the hope goes very much to every kind of alliances which can bridge the vernacularization of struggles, the fragmentations, and build, solidarities based on common demands, identifying common demands and building alliances, looking beyond the very particular struggles of the fragmented working class in this sector.
Thank you so much to both of you for joining us today and talking about this important book, not only in terms of how it talks about care work or engages with care work as an academic subject, but also, talks about the struggles on the ground. So thank you to Maaya and Christa, especially to Christa because she's joining us from a different time zone. So thank you so much. And it was indeed wonderful listening to you. To all our viewers, do get a copy of the book, read it. It's a very important piece of work. Thank you so much.
Most welcome.